We all have the myopic heavy eye syndrome. This is an acquired form of strabismus occurred in high myopia cases characterized by esotropia and hypotropia, limited abduction and elevation. And we all know that there is a herniation of the globe between the superior rectus and lateral rectus muscle due to elongation of the globe. And we diagnose it either clinically, which is very common to be diagnosed clinically, or by confirmation by the MRI, and to diagnose it according to the angle of dislocation between the superior rectus and the inferior rectus muscle on MRI. As you see, you just request an MRI and see the angle between the superior rectus and lateral rectus. If it exceeds 100 or 120, 100 up to or 180, so it is increase the angle of dislocation, and you have a case of myopic heavy eye syndrome. The previous things are already well known, and I think the diagnosis mainly clinical. I adjust as I just mentioned, and MRI is confirmatory. But in cases you suspect that you have a myopic heavy eye syndrome, by intraoperative exploration, you might find the deviation or the displacement of the superior rectus and lateral rectus by exploration of the muscles. So I have a small tip that would help you to suspect, because some cases you just enter and just enter in the operation, started the operation, and you did not think the patient and you have a differential diagnosis already. You're not sure the patient had already a myopic eye syndrome, myopic esotropia. So please explore and just to hook the superior rectus, and you will see very clearly the insertion of the superior oblique muscle widely showed lateral the superior rectus, and even the lateral rectus muscle, you can see the insertion of the inferior oblique sometimes above the muscle instead of being below the muscle, because the lateral rectus is severely displaced downside, down. Yeah. Okay, so in those cases, you can depend on your intraoperative exploration and don't ask for MRI. This is a very important tip to explore. But in the literature, it was mentioned that heavy eye syndrome rarely or not typically present in children. And today I will show you some cases that I found that they had already a heavy eye syndrome, myopic heavy eye syndrome, while they are still children and they are not reported in the literature. And so this is one of the drawbacks of the myopia, that we should control by atropine or the spectacles to avoid this pathology. I have 3 patients, two with anisometropia and one without anisometropia, without evident anisometropia. In the case, the first one, he had right eye minus 9 diopters, left eye plano, and he had an gradually increasing esotropia, and by MRI I found that he had increased the angle of dislocation, and I admit the patient, and I made him medial rectusation and right Yokoyama, and he had a very good outcome. Another patient, I admit the patient for surgery. He had bilateral myopia and myopia with esotropia. I dealt with the condition that he had a regular myopia with esotropia, and I just did for the patient bilateral medial rectus recession, and I found that the patient before the surgery had esotropia of 40 present diopters, and then I was surprised after the surgery he had almost 30 present diopters, as if I did nothing. So I requested MRI for this patient, and I found that he had a shift of the superior rectus and the lateral rectus muscle, and then I readmit the patient, and I did for him Yokoyama to have his esotropia corrected, and he is stable for a long time. Another, the third patient, he had myopia with anisometropia in the right eye, and in this time I learned the lesson quite well, and I requested MRI just to make sure he had heavy eye syndrome, and I found that he had the same shift, and the patient was diagnosed with having myopia with heavy eye syndrome, and I made for him the Yokoyama. So heavy eye syndrome can present in children. although it is not reported in the literature. And this is my technique for Yokoyama procedure. This is how to do it very simply and very fast. So I just hook the superior rectus muscle and make a minimal dissection of the superior rectus muscle, and then I take a non-absorbable suture just 40 millimeters behind the insertion of the superior rectus muscle. I just take partial thickness, then full thickness, then lock the my knot, and then I hook the lateral rectus to make the intermediate. It is not reported that I need to make the scleral suture, but I do this modification, just a very superficial episcleral stitch suture, 40 millimeter or 15 millimeter behind the limbus in the midway between the superior rectus and lateral rectus muscle. So what is the value of this suture? The value of this suture is that I make sure that the superior rectus and lateral rectus will meet at the midway between the distance between the superior rectus muscle and the lateral rectus muscle, just midway, and I'm sure that the knot will stop at the episcleral, the superficial episcleral when I just try to tie both muscles together, the knot will stop at the mid distance between the superior rectus and lateral rectus exactly, without being shifted upward or being shifted downwards. So as you see, the knot just stopped midway. I don't need to make large exploration or make very large conjunctival dissection, just to hook the superior rectus and then hook the lateral rectus. Just make the superficial episcleral suture and then the lateral rectus suture, and then tie your knot many times, and then you will have the Yokoyama done. So this is the post-operative, immediate post-operative results of those patients. There is a modification of Yokoyama procedure. If anyone find it is difficult to do the Yokoyama, you just split the superior rectus and the lateral rectus muscle into two halves, and then make exchange. You suture the superior rectus above the lateral rectus muscle, and the upper half of the lateral rectus behind the nasal half of the superior rectus, and you will have some sort of support and decrease the herniation and prolapse of the eye globe. And it was described by S. Young. And that's all, and thank you.
Thank you very much. Thank you very much for this nice presentation. Are there any questions from the audience? What about our panelists? Would you like to ask?
Just to support your idea, I have two children with heavy eye syndrome, one with anisometropia and the other with glaucoma, congenital glaucoma. So you are right, I'm with you. Thank you.
Sure.
Just a quick comment that, it's absolutely true that this happens in children, but sometimes they don't have high myopia. Sometimes they have low myopia and they get it. So they don't have to have high myopia. Sometimes low myopia patients get this phenomenon.
I agree. I can't agree more, because I have many cases with sagging in young age and without myopia. So I was just preparing to publish many cases with such disease. So sometimes it is a degenerative disease, not only related to myopia, and not like the sagging, which is related to the age. It's not related to the age and not related to the myopia. It is just a degenerative disease of the ligament between the superior rectus and lateral rectus muscle. Thank you for your comment.
Just one last question. Do you add mid rectus recession in these cases, or just do Yokoyama? Because in adults, sometimes it's recommended not to do recession.
According to the angle, but yeah, sometimes you have an angle just of 15 present diopter, 20 present diopter. You might be afraid to add medial rectus muscle, but I noticed that in most cases you have to do medial rectus recession in conjunction with the Yokoyama.
Hey, last question, small, quick one. Can you louder?
Sorry. How do you titrate the medial rectus recession with the Yokoyama? I mean, based on what, like table or the amount of the medial rectus recession?
So,
Or would you prefer like as a
every surgeon is lucky with certain type of cases. So I have many cases with heavy eye syndrome and sagging eye syndrome in my clinic. I don't know why. It's just luck. So I have experience on many cases, and I find out that the Yokoyama procedure just correct about 15 to 20 present diopter maximum. So if you have an esotropia of 40 present diopter, just make medial rectus recession 6 millimeters and your Yokoyama and just wait. If you have more, and it's very common to have more angle in older age, so you need to do bilateral medial rectus recession as well and the Yokoyama.
Would you prefer like as a one-step surgery or like a two-step surgery? I mean, do the
Yokoyama
Yokoyama...
According to the angle. I just mentioned, according to the angle. If I have 40 present diopter, I would go for ipsilateral medial rectus recession only and Yokoyama procedure only. If I have more, I would go for a medial rectus recession in the contralateral muscle, contralateral eye.
Thank you very much. Thank you for being together with us here at the last session of the day, at the last session of the Congress. I think there will be the closing ceremony after this one.
There is Dr. Nisar Riyad.
No, I think now after this one. Okay.
Is he absent? Dr. Nisar Riyad?
Okay.
From Iraq?
Sorry? We finished.
Okay.
Thank you very much.
We will have the closing ceremony within few minutes. Just we will open the separation between two holes and we will start. Okay. We will not take a long of time. Only 3 hours, 5 hours like this, and you will stay here. How's it?